Hey folks, before we get to the show, Nick and I have a very exciting announcement for you guys. We are super excited to be presenting our Critical Care Time store and newsletter, which are now live.
That's right. You can subscribe to our newsletter to hear updates about the show. You can also go to our store and pick up some really cool Critical Care Time swag.
That's right, Nick. So guys, just head on over to the website. That's www.criticalcaretime.com, where you can navigate to the store or sign up for the mailing list.
And add yourself to the mailing list. Be sure to do both.
Of course, make sure to sign up for both. And on that note, with respect to the newsletter, we're going to have some brief synopses of shows that we've recently recorded. We're going to cherry pick some articles for you and have some comments for you guys to enjoy. And finally, anything we're into, any insights into this, that, or the other, we'll make sure to throw those into the newsletter as well.
So get excited. And now, back to the show. I think the funny thing here, there's this joke, right? Like, how do you hide $20 from a medicine doc? You put it under a dressing. How do you hide $20 from a surgeon? You put it in the chart. You kind of need both here, right? You kind of need to like assess the patient and assess the chart to do this right. And so one of the things that I always try to do when I'm trying to figure out if an airway is going to be difficult is search for prior intubation notes. Depending on what EHR you have, you can search other connected EHRs, like with Care Everywhere. Really important to do that because you will identify a lot of problems before you charge right into them. Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your host, Dr. Nick Mark.
And I'm Dr. Cyrus Askin, your other host. On this week's episode, we're going to continue our conversation from season 1, talking about difficult airways.
Back in episode 11, we talked about the physiologically difficult airway. In this episode, we're going to take on the sequel and talk about the anatomically difficult airway.
That's right, Nick. And hopefully this will be one of those rare examples where the sequel is actually better than the original.
GF2.
Empire.
Aliens.
Dark Knight.
Wrath of Khan.
Addams Family.
I think that's Addams Family Values. So anyway, Bride of Frankenstein.
Yeah, I would also say the second Dune movie.
Yeah, I'll give you that.
But okay, anyway, we could probably do this all day long, but we'll save our audience that pain and suffering, and we'll move on to this great episode. I think it's going to be super exciting. We're going to start our discussion by talking about some of the factors that can make an airway challenging and the tools that you can use to maybe predict a difficult airway.
Then we're going to talk about how we can sort of modify our approach, and then we'll use a couple of cases to illustrate how we can apply the techniques we talk about.
Exactly right. And then we're going to conclude by talking about some common mistakes we've seen and read about.
It's going to be a blast. Buckle up, everybody. This is going to be a lot of fun.
So, Nick, maybe we should first define for our audience what is a difficult airway from an anatomic perspective.
Great starting point. So I would define it as a situation where a skilled operator has difficulty intubating a patient. That's like a stupid, obvious definition, but I think it's important if we draw the contrast to the physiologically difficult airway, where the problem was the physiologic derangements that occur with intubation. In contrast, the anatomically difficult airway, it's going to be just physically difficult to prepare the patient, get the view, and pass the tube through the cords. So it's a problem of getting the plastic where you want it, not a problem of the physiology doesn't tolerate it.
That's right, Nick. And I don't think these are mutually exclusive either, right? I mean, you can have physiologically difficult airways in a patient with difficult anatomy. And of course, that lends itself to a pretty tough situation, I think.
Absolutely. This is not, one or the other. Often these two birds of a feather fly together. So let's kind of break it down now. So intubation is a complex series of actions that all have to go right in order for the intubation attempt to be successful. Another way to put this is that if you have problems with any of these steps, it can make an airway difficult.
Absolutely. So I think we should probably think about the steps in particular and how they can each go wrong. So first off, we've got problems with the face mask and bagging. So this could be as prosaic as perhaps having facial hair in the way.
And preparing for this episode, I did some research, and it turns out that we are probably at peak beard in the last half century. According to a 2023 YouGov study, 34% of men had a beard or mustache, a 50-year high. So there's a lot of beards out there interfering with this.
Yeah, and kind of right up there with the beards, people that have a little extra soft tissue in the face, often associated with obesity related problems like obstructive sleep apnea. So that's a problem too, right, Nick?
Absolutely. According to the NIH, we're at like an all-time high. 42% of American adults are obese and 9% are severely obese. So these are two very common problems.
Right. And fortunately, we never encounter an obese patient with facial hair, so that's
Right.
good.
Santa
Never
Claus.
a thing. Yep. There you go. And so on that note, so there are some less common but very significant factors we should consider too. So things like patients that lack dentition, patients that have facial trauma, those with recent head and neck surgery, and also those with bleeding, vomiting, things of that nature.
All of those things can make it hard to bag, valve, mask this person.
Mhm.
Next up, we should talk about problems with positioning. So this is where it's going to be hard to get the head in the position you want in order to place the laryngoscope. So this could be things that the person has always got, things like a short neck or kyphoscoliosis. It could be things like they've had a spinal fusion, so they can't extend their neck. Or it could be something more immediate. It could be like they're a trauma patient and they're in a C collar, which is directly limiting mobility. But anyway, all of these are going to make it harder.
That's right. And then, kind of moving on from there, you've got issues with sort of accessing the mouth itself. So you could have impaired or limited mouth opening. You could also have, again, facial trauma, maybe a wired jaw, for example. That's obviously going to make it difficult for you to insert anything into the airway itself.
These are really scary situations when you see them, and it can be really challenging. Another category of problems is when you can't see the cords. This could be because the airway is contaminated. There's blood, vomit, excess secretions that are obstructing your view. It could be because the anatomy of the airway is abnormal. This could be somebody who just has an anterior airway or some other variant. Or it could be because the anatomy is distorted. Imagine somebody who's got trauma or edema of the face or edema or swelling of the vocal cords. It could also be something like an abscess, like a retropharyngeal abscess or a hematoma, which is pushing and moving stuff over in strange ways. So all of these can make it very, very difficult to visualize your target.
And again, Nick, terrifying to see if you're not anticipating it. You know, you've got your patient set up, you're ready to intubate them, you take a look, and you don't see what you expect to see. Um, definitely a worrisome situation to find yourself in. Similarly, you may actually be able to see the cords, but still have difficulty passing the tube itself. And so that can occur if just the positioning of the cords, maybe again, that distorted anatomy, maybe they're just more anterior than you expect. You could have kind of fixed vocal cords. So vocal cords that don't open the way you would expect them to, resulting in a narrow opening, a small aperture for actually passing that tube. And then additionally, kind of beyond the cords themselves, you can have tracheal stenosis, you can have tracheomalacia also can be a problem, potentially compression of the trachea due to tumor. So all of those issues can contribute to difficulty completely passing the tube.
So just to summarize kind of everything we've talked about there, there's kind of many different ways that you can run into trouble. You can have problems bagging to pre-oxygenate. You can have problems positioning. You can have problems actually physically getting the laryngoscope into the mouth. You can have problems visualizing the cords, or you can have problems passing the tube. That's a lot of different ways for this complex process to go wrong. And so when we're planning intubation, we need to really think about all of these factors. Sometimes the anatomically difficult airway will be really obvious. For example, you have a motorcycle crash victim with facial trauma in a C collar. They've got clearly distorted anatomy. You can tell from across the room. There's blood contaminating the airway. Anyone can look at the situation and expect a difficult airway.
And conversely, they could also be subtle, right? So you could have a 60-year-old who, you don't realize is wearing loose-fitting dentures. They have OSA. They've maybe had a spinal fusion in the past. They've got neck radiation for anaplastic thyroid cancer. Oh, by the way, they've got a giant beard. Some of those may be readily apparent on exam, but a lot of those you wouldn't notice. And so that confluence of factors can be really challenging to overcome. And so it's really important to do a good chart review, ask the right questions, do a physical exam, all those things, assuming you have time to do them.
Exactly. And I think that this is a situation where we need to sort of do everything we can to anticipate so that we can plan.
Yep.
So now that we kind of understand what the anatomically difficult airway is, we can talk about kind of structured ways that we can anticipate it. I want to start by saying, I really love this quote by astronaut Frank Borman. A superior pilot uses his superior judgment to avoid situations which require the use of his superior skill.
Yes, and so in our line of work, it would be a superior intensivist uses his or her superior judgment to avoid the difficult airways that would require the use of their superior skill.
Yes, and thank you for fixing Frank's gendered rule there. I like that.
Yes.
Sometimes the most important thing that you can do actually is determine that an airway is going to be hard and make plans accordingly. Because sometimes if you know an airway is going to be hard, that means you shouldn't be the one to do it. Maybe that means you're going to intubate somebody in the OR where they have all the toys, with an ENT surgeon ready to go with an emergency front of neck airway, and you've got your other surgeons ready to place ECMO cannula. If you know something is going to be hard, there's no reason that you have to be the one to do it if somebody else might be better.
It's an excellent point, and I think we're going to circle back to that a few times during the course of this episode. That's that concept, but fortunately, there are at least several tools we can use to help us predict a difficult airway, and there are four mnemonics in particular that we're going to unpack here in a little bit. So there's moans, which would be kind of difficult to bag; lemon, which would be difficult to intubate; rods, which would be a difficult supraglottic airway; and then short, which would be a difficult emergency front of neck airway, or ephona. We'll use that term as well. So we'll first unpack moans. Again, that's the difficult to bag patient. So that's someone who's got a challenging mask seal due to a beard, blood trauma, anatomy, etc. Perhaps someone who is then obese, so that's the O, or has obstruction, another O. If they're age, so age greater than 55. If they have no teeth, so that's the N, no teeth. And then finally, if it's someone who's got sleep apnea or stiff lungs, so someone with COPD, asthma, ARDS, that's the moans mnemonic for you.
And I should say that some people like bones instead. Bones stands for beard, obese, no teeth, elderly, or sleep apnea or
Nice.
snoring. I mean,
Sweet.
so, moans or bones, five sort of things to watch for, five letters that can predict difficulty bagging. Let's move on now to another common one, which is lemon. This predicts somebody who's going to be difficult to intubate. So the L stands for look at the head neck. E stands for evaluate the 332 rule, which we'll talk about. M stands for the Mallampati score, which we'll also delve into. O stands for obstruction, like OSA, obstruction. And then N stands for neck mobility issues. So kind of parsing that little by little. When we look at the head neck, we're looking at those factors we talked about before. We're looking at, issues where there may be distorted anatomy, there may be other externally evident problems. This brings us to the 332 rule, which is a great rule. It kind of has, three parts, three measurements. The beauty of this is something you can measure quickly with one hand just by putting your fingers against the person. And it comes down to three things. So first, you're going to measure the interincisor distance. That's the distance between your top teeth and your bottom teeth. If you can get 3 fingers or more between open incisors, that's good. That means that you have plenty of room to put a laryngoscope in. Imagine somebody has like a jaw problem where they can't open their mouth that wide, or they have some other problem which causes narrowed mouth opening. You're not going to be able to get 3 fingers. That's a red flag. The next one is hyoid mental distance. So this is basically the distance from your chin to your hyoid bone. You want to have at least 3 fingers there. If you have fewer, it suggests that your hyoid bone is going to be relatively anterior, and that may make the airway harder to visualize, harder to pass a tube. And then finally, we have the hyoid thyroid cartilage distance, or HTD, which is basically the distance from the hyoid to the thyroid, which you want to have at least 2 fingers.
Excellent. And really, yeah, so if any of these distances are less than 332, it portends difficulty.
Next, we have the Mallampati score, which is something that a lot of people are familiar with. This is basically a technique where you look at the person straight on, you have them open their mouth, and you basically evaluate the view, what you see.
That's right. And so there's basically kind of 5 groups, 0 through 4. A 0 would be any part of the epiglottis is visible. Don't see that a ton. Class 1, class 2 is probably what we're more familiar with. So class 1 would be you can see the soft palate, the uvula, and the pillars. 2 would be soft palate and uvula are visible. That's probably the maybe that's the most common is the class 2, maybe class, borderline class 1.
I think it depends what state you work in.
Very fair, yeah. Class 3 would be that only the soft palate and base of the uvula are visible, and then finally class 4 is that you can only see the hard palate.
So 2 comments here. One is that I think it's super confusing that the modified Mallampati score goes from 0 to Roman numeral 4. I think it's like missed opportunity to make this simple.
Yep.
It's worth looking at if the person can do it with you, but remember that it is not super sensitive. More on that in a second. So closing out the rest of the lemon score, obstruction we talked about, neck mobility we talked about. So remember lemon.
All right, so we do have another two mnemonics we want to unpack for you. The first is going to be RODS, and that refers to that difficult supraglottic airway. So with RODS, the R is going to stand for restricted mouth opening. The O is for obstruction, specifically airway obstruction. The D is for a distorted or disrupted airway. And then finally, the S is for stiff lungs or a surgical spine. So those are the elements of RODS.
And it kind of makes sense if you think about it. I mean, the idea when you place an LMA is you really have to open the mouth very wide to get it in there. So mouth opening is going to be a problem because it's not going through the vocal cords. If there's airway obstruction present, it's not going to fix that problem. And then because the LMAs are basically designed to sort of fit the average person airway, if there's distortion or disruption, it's not going to work. And then finally, it doesn't get a perfect seal. So if you have really stiff lungs, you may not be able to apply the requisite pressures through an LMA. So you may get inadequate ventilation. So it's a useful mnemonic, probably one that we ought to use more, in fact.
Yeah, definitely good points, and a couple points to piggyback on. So the LMA is a trade name. A supraglottic airway, or SGA, is actually like what you're placing. Many of us are fortunate enough, I think, to use the iGel, which is another brand. They do not support or sponsor us. We just see them and I think like them in general.
We do not get money from Big Airway, sadly.
No money from Big Airway. But I mentioned that because knowing the sizing and selecting the appropriate size for your patient is one way you can navigate this to an extent. So all supraglottic airways are definitely not created equal. The other thing I was going to mention, this kind of piggybacks on Nick's point, is if you've got someone who's on very high PEEP, and again, that's like stiff lung type patient, a supraglottic airway may not be as effective as you need it to be. So it may still temporize things and buy you a little bit of time, but really those are folks who are not going to be able to ride on a supraglottic airway for very long, if at all.
Excellent points.
Thanks. So moving on then to the last mnemonic is short. So again, short is for that ephona situation that may be tougher than you'd like it to be, if you will. So the S in short stands for surgery. So someone who's had surgery of the head, neck, thyroid surgery, etc. H stands for hematoma. Also, you could consider infections, abscesses, things of that nature. And then finally, we've got the O, the R, the T, which stand for obesity, radiation, and tumor, respectively.
Great. And so I think, these are great mnemonics. These are very useful for people who are learning to intubate or people who intubate less frequently. The good news is you can print these out and you can very quickly scan through and sort of identify if you have them, but they have limitations. And I think my biggest criticism of these is that none of these includes the single best predictor of a difficult airway, which, Jeopardy sound, is a history of difficult airway.
Yes.
Right. And so, I think the funny thing here, there's this joke, right? Like, how do you hide $20 from a medicine doc? You put it under a dressing. How do you hide $20 from a surgeon? You put it in the chart. You kind of need both here, right? You kind of need to assess the patient and assess the chart to do this right. And so one of the things that I always try to do when I'm trying to figure out if an airway is going to be difficult is search for prior intubation notes. Depending on what EHR you have, you can search other connected EHRs, like with Care Everywhere. Really important to do that because you will identify a lot of problems before you charge right into them. I think as a quick additional note there, if you encounter a difficult airway, be sure to document the heck out of it. Make it easier for that next person. In our EHR, we actually developed a flag so that if somebody has ever had a problem list item called difficult airway, then they always get a flag right when you open your chart. So I think system approaches are also important here because there's no reason that you should have to scour the chart for something that should be popped up in your face.
Super great points, Nick, and kind of a throwback to our discussion of heparin-induced thrombocytopenia with Matt Rindo, where we talked about putting that in as an allergy, using that allergy portion of the chart as a means to also highlight things that may not be allergies per se, but you definitely want the next doc or PA or NP or whomever who's going to be caring for this patient to know that this is a relevant element of their history. And I think getting back to the topic of discussion here, it's also really important to ask yourself: is this a situation that could deteriorate quickly, or is it a situation that is guaranteed to be challenging? So really, like framing the problem in that manner of like how likely is this to be a really difficult scenario.
Right, exactly. Because if it's something that might be hard, you can plan for it, you can prepare for it. If it's something that's guaranteed to be hard, you really should be asking, like, am I the one to do this? Can I, is there a better way to do this? Like we'll talk about some cases later, but I mean, sometimes the better part of valor is discretion, right? And so a big part of why we assess is to identify those disasters before they become disasters.
Very
Um,
true.
I guess I'll sort of say that I sort of take a slightly different approach from these, but I'm sort of incorporating a lot of these elements. I sort of think about it as sort of like read, ask, examine. Read the chart if you have time. Look at those prior procedure notes, medical surgical history, et cetera. You'll identify a lot of these problems from the chart. Um, sometimes you're in a situation where you just don't have time. You're like getting ready to intubate this person, but that doesn't mean you can't do this.
Yeah, that's right. I mean, you can also it's rare that you're intubating someone in a vacuum with no support, no assistance at all. And so oftentimes you have actually probably more hands on deck than you need. And certainly one of those individuals can quickly take a look at the chart in an emergent situation and give you some of that relevant information.
Exactly. I've had students do this for me before, like hit command space and type intubation. Okay, read me that note. Okay, now look at this. Now look at this. Like, you can get the information even if it's not you reading it.
Hmm.
Next in that read, ask, examine framework is ask the patient, have you ever been intubated? Frankly, this is not as important as the other question, which is, do you want to be intubated? But it's close. If they've been intubated before, were there problems? This can potentially capture some difficult airways that might have occurred outside of your EHR. Last step, let's examine the person. So, this is a couple of things borrowing from all those mnemonics, but like tilt your head up and down, open your mouth wide, how many fingers fit in your mouth, like the 3-3-2 rule. What do you see? Mallampati score, feel the hyoid mental distance, hyoid thyroid cartilage distance. The other thing that I like to do at this point is something called the laryngeal handshake maneuver, which is kind of a way to figure out anatomy if you end up in a situation where you need to perform an emergency front of neck airway. Basically, what you do here is you put the index finger and thumb on either side. And then you can kind of roll the larynx side to side. And you'll notice the larynx is kind of conical shape. It narrows as it goes down. So then you can slide your fingers down and slide your first finger down the middle. And you sort of feel each bump, and you can find where the cricothyroid membrane is.
Yep, and I think it's funny, Nick, because I always I find that like such a silly term, the laryngeal handshake. It's such a silly term. Like I don't know what we're getting into here, but the funny thing is like as I read about it, I realized like this is something that I was doing like without even thinking about it, just kind of like obtaining a tactile understanding of the anatomy to sort of inform future decision making.
Yeah, and it's great. I mean, and you can do this. You can do this from the head of the bed, so you can be reaching in front and feel it. And that can also be helpful if you end up needing to do external laryngeal manipulation as part of your intubation. You've kind of already felt like, oh, that's what it feels like.
Yeah.
So very useful. I want to highlight a really slick study they did where they used point of care ultrasound to mark the cricothyroid membrane using invisible UV ink. And then they had anesthesiologists do different maneuvers to try to find the CTM, and they marked it with visible ink. And then they shone a UV light on it to compare, like, magically reality gold standard POCUS versus what they thought. And the laryngeal handshake maneuver was the best method for this.
Cool.
I think it's also kind of a good reminder that we have point of care ultrasound. If this is somebody who is stable enough for you to take a minute or two to prepare, you can use point of care ultrasound to identify the landmarks for an emergency front of neck airway. Just save you time later, boost your confidence later.
Yeah.
And I think, if you see something and you mark it, I think that definitely will save you some cognitive load later on.
Yeah, and I think it's just like another pitch for pre-planning. You know, so many of our episodes, one of the key takeaways is plan, plan, plan. The exercise of planning is often very valuable, and oftentimes your best laid plans may go awry, but just having thought through the various scenarios and what you're going to do and how you're going to address these problems that might come up can be tremendously valuable. And the other thing I'll say is that really what we're doing here is as much about psychologically lowering barriers as you sort of alluded to, as it is about just that anatomy acquisition, preparing for ephona. Because really, it's cutting the neck is not a joke. It's a pretty significant intervention. It can be pretty gruesome, I'll say, at times. And so we want to do everything we can to set ourselves up and our patients up for success.
Right. And a lot of that is, if you need to do it, be prepared to do it. Because, yeah, like you said, psychologically, lowering the barrier to doing a life-saving procedure is really important. We've quoted Dr. Michael Tyson before on this podcast.
Yes.
Everyone has a plan until they get punched in the head, and unfortunately,
I think it's the
even
mouth,
if you,
actually.
oh, in the mouth. Oh, sorry.
Yeah, we don't want to misquote the doctor.
I definitely do not want to misquote Tyson. Unfortunately, even if you do your assessment right, there's still a reasonably significant risk of the unanticipated difficult airway. So according to a meta-analysis of over 50,000 patients, difficult airways have a prevalence of about 5.8% in all intubations. I would argue that that's an overall cohort, and it's probably even higher among people with critical illness, because many of the things that make them critically ill also cause difficult airways. In this meta-analysis, one of the things that they did was they sort of compared the different maneuvers that we just went through. And I'll just read what they said here. Each test yielded poor to moderate sensitivity, 20 to 60%, and moderate to fair specificity, 80 to 90%. So remember that every one of these tests individually is kind of meh. It's going to miss a lot of difficult airways, but by combining them together, you can make it more valuable. So in this meta-analysis, they found that combining Mallampati and thyromental distance together was really powerful. That had a likelihood ratio of 10. So I think the point is, be thoughtful, read, ask, examine, and use multiple different maneuvers to try to catch it, because that's better than a single test alone.
Exactly right. It's kind of a humbling reminder that even if you do everything right, you'll still occasionally be surprised. So now that we've outlined how you can hopefully predict the anatomically difficult airway, let's talk about some of those questions that we should consider when we're planning for them. And we'll kind of go into some general approaches here first.
So I think the first question is, who's going to do it? Is this we have one shot situation, an airway that's swelling or bleeding that could get worse? Or, it's a situation where we truly need to put our best foot forward, our best operator needs to take the one shot at this? Or is this a situation where it's going to be challenging, but maybe somebody who's a little more junior can do it with coaching from somebody? I think that's a good question to consider, who is doing it?
Absolutely. And it's a question that really should be answered with your ego off to the side, right? I mean, you should really be making this decision based on what's in the best interest of that patient given the circumstances.
Absolutely. Maybe another way to frame this question is like, am I up for this? Is this an airway that I should be doing, or should I be like getting, anesthesia, ENT, and others to come to the bedside, and we will do this all together? I think that's a crucial question to ask. Next, we need to really clearly assign roles, right? This is going to be a stressful situation. Everyone should know what they're doing. So, for example, who's pushing meds, who's bagging. We talked about who's intubating, but if there's multiple intubators, I think we should think about some of the details. So, like, you could think about this as like a pilot, co-pilot, or pilot flying, pilot monitoring analogy, where one person has got their hands on the controls and the other person is like running through checklists and helping them. You could say things like, okay, I'll be right here on your right side. I'll hand you the tube. If you need it, I will have the bronchoscope ready with an endotracheal tube loaded.
That's right. And then also having kind of a plan for if roles need to switch. So, how are we going to communicate that? I think that's a good idea. And it's especially important to establish those parameters for communication if you're working with someone you don't know well or you haven't worked with before.
Exactly. If you're meeting somebody for the first time at the head of a difficult airway, it's good to be explicit about these things. A couple other roles, that we should think about. Sometimes, there's a risk of tunnel vision, especially when you're trying to do a difficult mechanical task. And so especially if you have extra people, empowering one person to sort of, call out the time and pulse ox. We're 30 seconds in, sats are 95%. We're 45 seconds in, sats are 92%. You can kind of think about this as like the altitude alarm on a plane, like, as you're getting lower. But it's important for everybody to have situational awareness. And hopefully that person feels empowered to be like, okay, it's been a minute, sats are 70%. What are we doing? And push you a little bit in case you're tunnel visioned. Next, probably a role that's like very missed is this idea of the equipment runner. So like we probably don't have every single piece of equipment in the room, right? If we're especially in the ICU, this is in the OR. So who is going to grab the blank if we need it? And make sure that that person knows what the blank is and where it is. Because sometimes, under stress, everybody who knows the crucial device's location is doing stuff. So making sure that there's somebody free who can do that. And then I think kind of most importantly, kind of explain. When you're assigning roles, explain what your plan progression is so we all have a shared mental model. That way, people know, like, okay, Dr. Mark's plan is we're going to try an oral tracheal intubation with this device. And if that doesn't succeed, we're going to try this other device. So that they're getting it ready for me. Instead of me having to ask for it, they're just like, oh, here it is.
That is so important, Nick. And, I think really the goal there is to make sure there are no surprises. Everyone has their roles assigned. And then also just making sure that everyone can follow along with the plan. So like when I'm at the head of the bed, the last thing I do kind of right around that procedural timeout is, this is my plan. Everyone listen. We're going to do A. If A doesn't work, we're going to do B. If B doesn't work and I'm calling for C, then I want someone paging the surgeon overhead because that means we're approaching surgical airway territory and I want another set of hands.
Exactly. Yep. You can't be too explicit and too clear when you're assigning roles and communicating your intent in the briefing. Another thing that we need to do is we need to optimize physiology, right? We have a whole episode on this, so go back and listen to episode 11, but briefly, things like pre-oxygenation, anticipating blood pressure issues, considering the effects of positive pressure and apneic interval. Remember that anatomically difficult airways are often associated with physiologically difficult airways, so make sure to consider those things too.
Yes, I totally agree. Another question that's kind of part and parcel of this is how do we pre-oxygenate effectively? That's a big element of setting ourselves up for success. So just as a reminder, as far as the physiology is concerned, we want to increase alveolar oxygen as best we can. So remember the alveolar gas that, is present when you're breathing ambient air is 21% oxygen versus a nearly five-fold increase in that after effective pre-oxygenation. So, you're pre-oxygenating with 100% oxygen. The goal is to achieve a five-fold increase in how much oxygen is physically in the alveoli. And the better you're able to do that, the more effective you are, really the more time you buy. And furthermore, this of course is going to also improve how much oxygen is bound to red blood cells. So going from, for example, 95% SAT to 100% really is going to provide some additional reserve that could help you out if things get hairy.
And it's pretty remarkable too. I mean, there are studies where you take healthy volunteers and you pre-oxygenate them and you have them hold their breath, and people can hold out for a really long time, like 8 to 10 minutes if they're pre-oxygenated. So it really makes a big difference. And it's really important to achieve as much of that as possible.
That's a great point, Nick. And so as we sort of tease this out a little bit more, we can talk about things like non-invasive positive pressure versus mask versus BVM. And this was kind of discussed in part when we were chatting with one of the authors from the pre-oxy trial during our episode kind of towards the end of season 1. So really the bottom line there was that we would highly recommend the use of non-invasive positive pressure ventilation as a standard. In the pre-oxy trial, they really did effectively, I think, demonstrate higher mean airway pressures and higher FiO2s that resulted in fewer desaturation events.
And importantly, fewer episodes of cardiac arrest with induction. So not only do they oxygenate better, but potentially reducing adverse events. That's actually a great transition. So pre-oxygenation is important, but let's talk about apneic oxygenation for a second. And this is something where I think there's a lot of misconceptions about it. It's kind of confusing, right? And it's kind of a bit of a riddle if you think about it another way. Mm-hmm. How can somebody who's not breathing, you've given them paralytic, they're not breathing at all, how can they benefit from more oxygen? Like, how does that get into their lungs? That seems like magic, right? Well, let's parse this a little bit deeper. So in the apneic person, even though they're not breathing, they still have red blood cells going by the alveoli. They're still extracting oxygen from the alveoli into the blood. And that causes there to be a pressure gradient between the trachea and the alveoli, where the alveoli pressure is getting lower. And so by having a pressure gradient, the same way that like storms move from areas of high pressure to low pressure on the map, if you have low pressure in your alveoli, you're going to get mass flow into the alveoli. This is called aventilatory mass flow. And so the idea here is that if we can denitrogenate the person, if we can remove all the nitrogen from their lungs and fill up the alveoli with just 100% oxygen, even once they're apneic, oxygen is going to continue to move from the alveoli into the blood, which is going to create a pressure gradient, which is going to move oxygen down the trachea.
And as a reminder, too, that's a strategy that we use for kind of generally small to maybe small, moderate sized pneumothoraces as a means to manage them non-invasively, right? So we enrich the oxygen content of alveoli, recognizing that the nitrogen content thus is going to be quite a bit lower versus the nitrogen content in the air in the pleura, and it's going to cause that gas exchange. We call that nitrogen washout. So similar kind of concept at play here, just trying to increase oxygen concentration within the alveoli by way of, in this case, apneic oxygenation. Really, the core concept here is that you've got oxygen that's continuing to move from the alveolus to blood. There's this pressure gradient from mouth to alveoli that pulls oxygen in, and this flow is going to flush the anatomic dead space, essentially. So it's kind of like, again, the anatomic dead space is sort of analogous to the pleural gas in the setting of a pneumothorax, and you're just trying to flush that out. And then really, when we're using nasal cannula, that's one thing. It's probably not going to be all that effective. But if we're using high flow nasal cannula, positive pressure, that's really going to optimize this effect and give us that additional oxygen flow that we need.
Exactly. Now, I think great physiology. The question is, how much does this clinically matter? So there were all these OR studies where they showed that people with obesity undergoing surgery with apneic oxygenation could maintain their sats for like 18 minutes, right? Like
That's
really
right.
incredible. Somebody's not breathing for 18 minutes, sats stay up. But then they did the fellow trial, which was an RCT of apneic oxygenation versus usual care that found no significant benefit to apneic oxygenation in critically ill patients undergoing intubation. But I think this is a good example, and we've talked about this before on the show, of a quote unquote negative trial that maybe threw the baby out with the bathwater, that maybe people drew the wrong downer conclusions about apneic oxygenation. And I think, specifically, this was a small study. It was only like 150 people, and they found a difference of the number of people who desaturated to less than 80 was 15 versus 25%, which was not a statistically significant difference, but geez, I mean, that 10% number needed to treat 10 to prevent a desat, that's a pretty good effect, in my opinion.
That's right. And it's also worth noting out that this N of 150 trial may have been underpowered to detect a small benefit. The pre-oxy trial that, again, we referenced earlier was almost 9 times bigger with over 1,300 patients.
So my take is I like apneic oxygenation. I think it's backed by great physiology. Admittedly, the clinical trial results are so-so, but I think they're limited by, power. I also think importantly, apneic oxygenation is low risk. It's not going to harm somebody. There's a lot of potential benefit and almost no potential harm. Admittedly, the study is showing you won't desat for 18 minutes, so probably not the typical situation that I'm in, but I still like it. I still use it, and I think it's a valuable tool. Cyrus, what are your thoughts on apneic oxygenation?
Absolutely. Yeah, I agree. I think it's a useful tool. Certainly, pre-oxy sort of turned us all on to non-invasive as a means of pre-oxygenation. I think apneic oxygenation is also a totally reasonable means of pre-oxygenating. Could potentially be used in tandem with BVM, with non-invasive. I think at the end of the day, it's like whatever strategy is going to be the most effective to increase alveolar oxygen tension as best you can is probably the strategy that you should be going with. And it's likely going to be a combination of the above.
And I think, just to be really specific on this, in the situations where I'm doing pre-oxygenation with non-invasive where I also want apneic oxygenation. You can't really use high flow because it's too big to get the mask on over it, but you can get a conventional cannula on there and you can just crank it up to 10 or 12 or 15 liters per minute. And that will get you some apneic ox. Maybe not as good, but better than nothing.
That's awesome. So I think moving on, Nick, there are some other useful considerations I think we wanted to shed some light on. Do you want to start by talking a little bit
Yeah.
about maybe location?
Yeah, so I think location or positioning kind of has two aspects, right? The patient's like, how are they positioned? But before we even get to that, where are we in this building? I would much rather do an intubation in the ICU than on the floor if I have a choice. But in many cases, the OR may be the best place. If this is somebody where we might need to crash them onto ECMO or do an EFONA, that's the better place for it. And so thinking that through, if you have the luxury of a few minutes, if you're stable to move and you're going with them, that may be worth thinking about. It's also worth thinking about, when you're maybe you don't have that luxury, but you're, on the floor. It's like, okay, should I bring the patient to the place that has my bronchoscope, my difficult airway card, etc., or should I have somebody run and bring those to me? So even if you can't maybe change locations, can you make the location you're in have more of the tools that you want?
And I think related to that, Nick, is not just where they're physically positioned, but how are they physically positioned? So location as well as like orientation, let's say. So, a lot of, I think, novice airway operators will have the, shoulders on a roll with the head cranked like all the way back, and you've got total misalignment of the various axes that you really need to have aligned in order to successfully intubate someone. I think both of us, Nick, are fans of the sort of sniffing position, or also referred to as the quote unquote beer drinker's position, to where like
I'm a fan of
kind
that.
of yeah, exactly. As am I. The whiskey drinker's position, I don't think has the same, I don't know, je ne sais quoi, but
Sippers, yeah.
yeah, exactly. But basically, the idea there is to have the head of the bed, or sorry, have the head of the patient kind of in line more so with the airway rather than cranked back, opening up the trachea, opening up the airway so that you can actually visualize it better. Other things you can do to help this out is you can put the patient in some reverse Trendelenburg. So basically, you've got the head of the bed up a little bit, legs down, so that any sort of adiposity, let's say, any additional tissue is kind of not right on the chest, making things a little bit harder. And Nick, what are your thoughts on that?
Yeah, completely agreed. I think one mistake people make sometimes is that they sort of raise the head of the bed, which kind of folds the person. Ideally, you want to take the whole bed and angle the entire bed. And the idea here is that if you fold them, you're kind of increasing abdominal pressures. And what you really want is the abdominal contents pulled down by gravity, pulling the diaphragm down, increasing the FRC. It's also use gravity to keep the gastric contents in the stomach.
Absolutely, Nick.
Um, Another consideration, this is kind of a big strategy consideration, is awake versus asleep. Now, obviously, most intubations are asleep intubations. We give somebody strong induction meds so that they're unconscious. We also give them paralytics, and then we place our airway once we've achieved both sedation and muscle relaxation. That said, there are some times when you want to preserve airway reflexes. This is especially useful when you're anticipating a difficult airway, when the person is doing a good job of protecting their airway and you don't want to screw that up necessarily. So I'll say we did a whole episode with the Poem Peeps about times when a bronchoscope can help you. And so we talked a lot about this there. I would suggest going back and listening to it. We can hit on some quick points. I think briefly, when you do an awake intubation, it's really important to topicalize the airway as best you can. You can topicalize the nasopharynx or the oropharynx, as well as the vocal cords, maybe all of the above, depending on what you're doing. If you have the luxury of some time and the patient's compliant, no reason not to get, all of the advantages you can.
Yeah, I think that's true. And I mean, there are different strategies for topicalization, whether that's lidocaine or benzocaine, or even, dare I say, cocaine is an option, although I think that's more rarely used. I've certainly used more lidocaine.
I've used it in the ICU before. The joke, the nurses always make jokes about like, oh, does it come with a rolled up dollar bill, blah, 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 blah. But like, I mean, it's a useful agent.
Yeah. Yeah, for sure. And so really, theoretically, lidocaine versus cocaine are going to be equally effective. Lidocaine is, of course, normally preferred per guidelines, but you do get that additional vasoconstriction of cocaine, which could potentially be helpful, especially in terms of mitigating risks of epistaxis. And then really getting to sort of the nitty gritty on how do you topicalize. Well, there's different approaches. You can nebulize. That might be better. There's some data to suggest it could be better, although it's maybe a little more dealer's choice than we would like to believe. You can have a patient gurgle potentially. What I've probably done most frequently is a combination of nebulization and then the atomizer, which is basically like a little tool. It's like a little straw almost with a nozzle on the end that allows you to spray a very fine mist of whatever it is you're using. So in this case, lidocaine, and really get far back into the oropharynx and get things nice and numbed up.
Another thing that we can think about is, our medications that we're going to use for awake. Ketamine is great because it's dissociative, it has analgesic effects, but it should maintain respiratory drive and maybe airway reflexes. Sometimes I'll combine that with a scopolamine patch to reduce oral secretions as well. And then dexmedetomidine is another nice option. If the person's hemodynamics will let you, this is a great adjunct to achieve sort of awake sedative state. And you can combine that maybe with some ketamine and definitely with some topicalization. And that will let you do a lot in the airway while the person is still breathing and protecting their airway. Turning our attention now to the asleep approach, we talked about this a lot in the physiologic airway episode, so I don't think we need to say as much here, but I think we're both strong fans of ketamine as opposed to other agents. In many shops, etomidate is used, and I think that's a good option. Maybe not as good, but I think both are clearly better than meds like propofol, which can have some pretty strong hemodynamic effects, even though they have a great quick onset.
Yeah, I agree, Nick. Just a couple of points from my practice. I think I don't use a lot of etomidate. I really like the ketofol approach. So like approximately zero point 0.5 mg per kg of ketamine and propofol in combination tends to be sedating enough for that asleep patient, but also it gives me some more hemodynamic stability when you get that endogenous release of catecholamine. So I think that's a nice approach. It works well. The other thing I'll do with ketamine in the sort of awake patient, if I'm trying to keep them awake, is I will combine it, dare I say, with a little benzodiazepine. So maybe a little bit of Versed or midazolam, a little bit of Ativan. Small dose can be helpful in sort of like getting them a little more relaxed up front to then tolerate the ketamine. Helps you potentially if there's going to be any emergence phenomenon from that ketamine. So I do like to use those two drugs in tandem. And like you said, Nick, there is, or as you kind of alluded to, there is a little bit of a walking the line when it comes to ketamine and trying to give the appropriate dose for sedation, but still awake and maintaining respiratory drive versus like fully sedated out and not breathing. Because I have seen that happen before.
Exactly. And I think the key is, you want to underdose and then redose carefully as opposed to
Absolutely.
overdose.
Completely. You can always give more. It's really tough to take away. So I think moving on, paralytic strategy. So this idea of rapid sequence versus delayed sequence versus no paralytic. So just to sort of run through some of this quickly for our audience. So obviously no paralytic is no paralytic. You're using sedation. You're not giving any sort of paralyzing agent. So no rocuronium, no succinylcholine, nothing like that. With RSI, really, you're pushing your paralytic and your sedation at the same time. That's probably what many of us are most comfortable with. You basically will give sedation, flush, paralytic, flush, wait a few seconds, take a look, and go. And then somewhere in the middle is this idea of delayed sequence intubation. And so in delayed sequence intubation, you are giving the sedation and you're waiting a period. You're using that interval to pre-oxygenate, and you're sort of like testing the waters a little bit. If that patient, when sedated, decompensates and you start to worry about giving paralytic, well, guess what? You didn't give paralytic. So you can sort of adjust fire from there. But on the flip side, you can take that interval to pre-oxygenate them a little more effectively, check the monitors, double check with the team, and then give the paralytic in perhaps a more controlled stepwise fashion. So I think that's a nice little rundown there. Nick, any specific points you wanted to mention in regards to any of that?
Yeah, I think so. Great summary. I think, I don't really view it as a choice between three options. I sort of view it as a choice between two. I think the no paralytic strategy is a little bit tricky. I think the question is, when are you giving the paralytic? There are some studies that show that intubation without the use of paralytic is associated with worse outcomes, increased aspiration, more airway trauma, increased mortality. In one observational study, we know from randomized trials that paralytics improve intubating conditions, better fewer attempts, less hypoxemia. I think really the question is one of timing. Are you going to give them both at the same time, your sedation and your paralytic at the same time to try to get conditions good as quickly as possible? Are you going to give delayed, where you're going to sedate and then try to get the person really comfortable, optimally positioned, pre-oxygenated, and then once things are perfect, give your paralytic? Or in some cases, maybe you're even going to go in awake and get through the chords and then give your paralytic. But I wouldn't recommend the routine use of no paralytic. I think it's a matter of when and how.
Agreed.
I have another rant on this. If you go back to Physiologic Airway about why I think rock is superior to sucks, in the interests of time and hate mail, I won't repeat that rant here. But send your comments to Cyrus_Askin. Just kidding.
Yes, please. We like rock. We'll just say that.
We like rock. Next, we should talk about kind of what is your approach. So we've gotten this person positioned, pre-oxygenated, apneic oxygenated. We've given them sedation. We've given them paralytic. How are we going to intubate them? So we could do an orotracheal approach or a nasotracheal approach are sort of our two big ones. Orotracheal, technically simpler. The mouth is bigger than the nose. We usually intubate through the mouth. This is kind of what we're accustomed to. But there are situations when nasotracheal may be the better option. It's generally more comfortable for people if you get a good job topicalizing the nose. It's a good way to take a quick look. However, it can be more technically challenging, especially if you've never done it before, and it can cause epistaxis, which can take a difficult airway and make it a really difficult airway.
I definitely agree. It's I suppose there's a time and place, but it is not an approach that I typically reach for. And what I'll say is that while there are observational studies that suggest nasotracheal intubation may actually have lower mortality, there are a lot of caveats to that. And I think one of the big caveats, at least in my mind, is how comfortable is the operator with that approach. I'll be honest, it's not something that I routinely train or routinely do. So if I'm thinking this person's going to need a nasotracheal intubation, I'm going to call a buddy to help me out.
Though I will say that this is, there's many training paths to critical care, and pulmonary is one of them, emergency is another, surgery is another, anesthesia is another, neurology is another. There's lots of ways that lead here. One of the advantages of people who are pulm trained is you've presumably done hundreds, if not thousands, of bronchoscopies through the nose. So
yes.
If you're comfortable with the mechanics of it, it's only a little bit different here. If you are picking up a bronchoscope for the first time in years, this is going to be a very hard approach. And I agree. This is a call a friend situation.
Yeah. I think for me, I do plenty of bronchoscopy as well. And I think a lot of us train through the nose first.
Mostly,
and for the most part, I think for me, I get a little, I'll be honest. I think if you're loading up a endotracheal tube on the bronchoscope to try to pass it through the nose in a situation that's potentially going to be dicey, I'm even though I'm very comfortable bronching through the nose, I think that additional element of having to get that tube in place is something that I would want to have some help. I think for the first one or two.
It's great to have another pair of hands. I think use a lot of local, use a lot of lube. If you can get the longer tubes, which are designed for this. And this is we'll talk about this more later, but I think this is something that you want to simulate and practice so that you're doing this with some cadence, because this is definitely like a sort of like high acuity, low occurrence procedure.
Perfect. Yeah. And then I think, Nick, maybe another topic we can sort of discuss is this idea of VL versus DL, which we discussed in the context of the device trial. What are your, I kind of know the answer already, but what's your thought on this, Nick?
Yeah, I think VL is superior. I think that we should be doing VL as our primary approach for critical care intubations. I think there's a couple downsides to VL. Sometimes it gives you a better view, but tube delivery can be harder. You're sort of looking around a corner, so getting the tube to follow your view is hard. And VL can be a problem in contaminated airways. As I've said on prior episodes, this is only true if you're doing hyperangulated blades, though. If you have standard geometry blades, if your view gets contaminated, you can just lift, and now it's exactly the same as if you have DL.
Exactly.
So I think sometimes the downsides of VL are overstated, and the advantages, even in contaminated airways, are not appreciated. Because, many times, even in a contaminated airway, VL works just fine. You lead with suction, you keep it dry, and it works great.
I
Just
agree with
because
you.
it's contaminated doesn't mean it won't work. It means it might go wrong. And so if you have a plan to deal with that, you're often okay.
Totally agree. And I think the one other thing we'll talk about here, because I don't really have anything else to add, because I think we're very much on the same page there. The other thing I'll add is this idea of the quote unquote fiber optic intubation, which is really a bronchoscopic intubation, the fiber optic being a misnomer, since really
Most of our
most of
scopes
the.
are disposable that don't have fiber optics in them anymore. So,
Exactly right.
but we like
But
to
yeah,
say it. It sounds cool.
it does sound cool. I think that that's obviously another approach. Generally speaking, we're going to use that in someone who either in the awake intubation, where we're sort of standing almost at the foot of the bed, looking face to face with the patient, sort of like introducing the tube in that manner via the bronchoscope. That's one approach that I've used. Helpful in folks that are going to be difficult airways in large part maybe because they're obesity. You don't want to lay them flat. You're going to have issues even getting them in that sort of reverse Trendelenburg position. That sort of thing. So that's one option. But in general, I think I've used it more as like an emergency option. I think rather than like a primary option in most cases. I don't know, Nick. What are your
Yeah.
experiences?
So bronchoscope has saved me and saved the patient many times in my experience. I've probably not done 5 or 6 ephonas because I used a bronchoscope successfully instead,
Mhm.
and I had it ready. And so I think as a rescue technique, it can be really valuable. It can be really helpful in a couple situations. One is when you can't get a good view. Somebody who, even with VL, maybe you don't have a good view, because then you can have one person lift the scope and another person pass the bronchoscope through the mouth, and then you can kind of curve even more to get that anterior airway. It can also help in a distorted airway because maybe the problem is that your scope is aligned for a midline structure, but if your structures are displaced to one side or the other, the bronchoscope doesn't care. The bronchoscope can turn. And then, it can also be, aside from finding the chords, it can also be good for tube delivery. Sometimes, you can see it really well, but you just can't get your bougie or your stylet to go where you want it to. And of course, the beauty of the bronchoscope is it's like a bougie that can drive. So in those situations, it's great. I've had a couple situations even where like your view is very distorted and you see like bubbles or something, and you go through it with the bronchoscope, and then you see that you're in the trachea. You guessed right. And I
Right.
really like it here because, in contrast to, say, a bougie, where maybe you push through, you see bubbles, you push through, and then you're like, did I feel rings? Maybe, maybe not. You have the absolute visual assurance that this is a trachea.
Yeah.
You see, you know where you are. So then you can slide your tube over it, and you're in.
Totally. Yep. I agree. I don't have anything I would add. Um, I think so. So moving on from there is we've talked about VL, DL, bronchoscopy. So what about tube delivery itself? So what I mean by that is there's different ways to sort of load your tube. That could be on a stylet. It can be on a hyperangulated stylet. It can be on a bougie. It kind of depends on what tool you're using. So with the bougie, the idea there is it's basically a very long, semi-flexible plastic. Kind of like a stylet. It's a long tube, not a hollow tube, mind you, and it's got a little crook on the end, almost like a little finger on the end. The idea there is that you're able to pass it, potentially even blindly, into the oropharynx. That anterior sort of finger type projection will hopefully lead you into the airway, and then you can kind of feel, in theory, the tracheal rings as you're passing that bougie, allowing you to then pass that endotracheal tube over the bougie, remove the bougie, and then you've got an endotracheal tube in the right place. So that's really the idea there. The kind of other options are your traditional stylet, which is a little more flexible than a bougie, quite a bit more so, actually. It allows you to really put a lot of flex into the endotracheal tube, but still gives it enough rigidity to actually get it from your hand into the airway. And then finally, this idea of a rigid stylet, which is really, as the name suggests, rigid. And so the idea there is typically that you're using it with a hyperangulated blade to sort of mimic the curvature of that blade, allowing you to potentially overcome some of the issues with indirect laryngoscopy.
Yeah, great summary. And I think, just a couple of points there. The stylet that's flexible is kind of a blessing and curse, right? It can be
Agreed.
too flexible. It may not, it may get distorted. Um, but sometimes, you're like, oh, I just need it to go there. And then you can kind of take the tube out, quickly bend it, put the tube back in and nail it. So sometimes it's really good to have a stylet. It's always nice to have the option of the rigid stylet versus a stylet. The bougie, you can't bend it and have it hold a shape, but sometimes by virtue of its kind of geometry and that sort of bend, it kind of goes where you want it to. I think in preparing for this episode, we kind of realized that neither one of us is like a huge bougie fan.
I would say, like apneic oxygenation, there was a lot of enthusiasm for using bougies to augment your intubation strategy. There were several, I think 3 observational studies, 1 RCT that found routinely using a bougie rather than just an endotracheal tube with a stylet was associated with an increased incidence of intubation on the first attempt. So that sounds great, right, Nick?
Right. And then there was a trial called the aptly named Bougie trial, which stands for bougie or stylet in patients undergoing intubation emergently.
Not a stretch at all.
I want to give them 9 out of 10 for the name of the trial. Very creative. RCT of like 1,100 critically ill people undergoing intubation. They found that first pass success was 80% with a bougie and 83% with a stylet. So a difference that was not statistically significant. So I think this kind of threw water on routine use of bougie. I think, as we were saying, we're kind of bougie nihilists, I think. Didn't really change my practice one way or the other. I think there's a time and a place for bougies. I think they're valuable. I think, it's not something that you want to only use when you have difficult airway. Like if it's something you use, you should use it sometimes in the mix to maintain that skill. It's a little different, and different people do it differently. Like some people like to preload the endotracheal tube on the end. So it's just a matter of sliding it in. Other people want to get it in and have somebody else do it.
Yep.
I think whatever you do the same thing consistently. Don't be like trying to figure this out on the fly in a difficult airway.
Yeah, I got a buddy who he showed me. He called it like the Kiwi grip or something. I don't know if that's widely referenced on the interwebs or whatever. But basically, like you take the back end of the bougie as it's sticking out of the endotracheal tube, and you sort of tuck it into the Murphy's eye to kind of keep it so it's not flapping in the breeze. And so then, yeah, it looks pretty sweet. And then you kind of, as soon as you get the bougie through the cords and you're confident it's there, you can kind of flick the tail of the endotracheal tube out of the Murphy's eye and just drop your tube. And I don't know, it looks pretty sweet. You get style points. Whether, how effective it is or not, I guess it depends on the operator. But, it's important to look good doing whatever you're doing. So
I'm guessing that's Kiwi for New Zealand, not for the food. But
I'm assuming so. Cool. We didn't really do a deep dive. I was just like, oh, that's pretty sweet. I think it's probably a good discussion thus far. Talked a little bit about approaches with the different types of scopes, the bronchoscope, the bougie, the stylet, all that good stuff. So. Maybe we can talk a little bit about this idea of ePhona. And so ePhona, again, that emergency front of neck airway, really, that is an option that it's, I want to say it's a last resort, but bear in mind, like when I say it's a last resort, that doesn't mean you should do it only if all else fails and you to the extent that you keep trying the same thing over and over and over again. I think we're going to talk about this a little later, but there comes a point when you really just need to cut the neck, and hopefully you're doing that on a patient that still has a chance to actually make it. Go ahead, Nick.
Yeah, so I completely agree. I mean, the situation that's sort of the most feared situation is the unexpected difficult airway that leads to a can't intubate, can't oxygenate, or KICO situation. This is where you basically failed with other methods and now you need to do something else. Yeah. And, we'll talk about what the approach is in a second. I want to draw a distinction, though, between that can't intubate, can't oxygenate KICO situation and the so-called surgically inevitable airway. Right. So there are some situations where like somebody has a large airway tumor, they're bleeding, obstructed, et cetera, which, or trauma, they've got a laryngeal fracture, jaw fracture, et cetera, where like in some ways that's almost like you shouldn't be viewing this as your rescue plan. You should almost be asking yourself, is this the right first plan? Should I be mobilizing the right people in the room to do this first? And so I think that's an important distinction, right? ePhona as rescue versus the surgically inevitable airway where you should really be prioritizing it first, or at least having those people in the room telling you, well, you can try from above first. And if it doesn't work, we'll do it. I just want to highlight one study from the OR literature, which is that Kiko situation accounts for 25% of all anesthesia related deaths. So this is really a highly feared, scary situation. It's something that you should practice your approach to individually and as a team. And it's something that like you should call out if this is a situation that's happening, right? Like this is like the engine out situation, like with Kiko, we can't oxygenate, we can't ventilate. We're going to proceed to, EFONA. And I think that's something where everyone in the room needs to understand that that's happening.
So, Nick, you alluded to this as we introduced the topic, but you mentioned an approach. Do you want to tell our audience a little bit about your approach?
Yeah, so and I'm hardly an expert here. I think I've done this twice, so that's not a huge amount of expertise. But the first step is you need to find your spot. You need a landmark, and ideally, as we said, you did this as part of your preparation phase, or at least you felt it and you have some mental familiarity with where it is. Obviously, it's nice if you've like found it with ultrasound and marked the skin. That makes X marks the spot, makes it a lot easier. By palpation can identify the cricothyroid membrane in about 70% of non-obese people and about 40% of those with obesity. So the flip way of looking at this is to say that palpation will usually fail you. So it may be quite challenging to palpate where you're going to go. This is why ultrasound can be useful if you know what you're doing. We talked before about the laryngeal handshake maneuver. The POCUS finding is kind of interesting here. So if you put a linear probe on the neck, you can see what's called the string of pearls, where basically you're seeing sound waves kind of going over the tracheal rings, and you'll see sort of a wider space, which is the CTM. Knowing where to go and making the decision is honestly the hardest part of this procedure. I think once you know where to go and once you're committed to this procedure, this is where hopefully training and simulation kicks in. You've done this a bunch of times on a mannequin. So you make your incision, typically, well, it could be either longitudinal or transverse. We could talk about that later. And then once you've gotten the visualization, then you make a transverse incision through the cricothyroid membrane. You turn the scalpel to widen it a little bit and give yourself a little room. You can get your finger in there past the bougie. I think this deserves its own episode. So nobody should be doing this based on what I've just described.
Yeah.
But I think kind of intellectually, talking about what this procedure is and remembering that the hardest part of EFONA is the decision to cut.
Nick, I think that's a great discussion. I probably don't I don't want to get too further into that because I think, like you said, it's probably fodder for another episode. But yeah, those high level points I totally agree with. Backpedaling a little bit to perhaps a concept that is maybe more germane in general to this discussion is the idea of suction. So what are your thoughts on effective suction? In that peri-intubation period?
So I think this is probably one of the most important but most overlooked aspects of planning a critical care intubation. I think this is one of the biggest advantages of doing intubations in the ICU or the OR, where you're likely to have multiple suction hookups and you can have the right suction tubing and the right catheters. I think it's very important when we say suction setups that it's plural, right? Remember that 2 is 1, 1 is none rule. Not only does this give you some redundancy in case one of them isn't working, of course you should test them so they're both working, but it also kind of lets you do things like you can use one suction, you can park it in the posterior oropharynx, and then you can use the other to sort of lead. So I think suction is very, very important. And we should also probably talk about like what the suction catheter is, because I think this is an overlooked variable a lot.
Yeah, I think that's a great great point, Nick. So there are different ways to approach suction in the airway. So what folks are probably most familiar with is the either the rigid yank hour, which is commonly used in most ICUs. Also, there's like the flimsy tracheal suction that's used for like NT suction. It's probably not going to be terribly useful in this situation because it just doesn't have a lot of. It's neither very wide, which we're going to talk about why that's important in a moment, but it's also very flexible. So it's very likely to get coiled in the airway, coiled in the nose. And it's probably not as relevant as a rigid yank hour. Other options include actually using an endotracheal tube on the end of the suction tubing. So you can actually do that. You can kind of shove the suction tubing on the back of the endotracheal tube and use that like on a spare endotracheal tube.
Especially if you have a
Um,
smaller size one handy. That's
yep.
good if your hospital doesn't stock some of these fancy catheters.
Exactly. Yeah. So like probably your Yankauer is what's going to be set up. If you need something beefier, then you could use that endotracheal tube trick. Or if you're lucky and either you have these in your go bag or your hospital stocks these, there's something that's made. There's something that's called a decanto catheter, which is kind of a little bit of a larger bore. It's a little beefier, pretty easy to maneuver, and that's a great option for decontaminating an airway. Like I said, it's kind of like it's wider, it's a little squatter, and so not surprisingly, it does achieve better flow rates. And at the end of the day, at the end of the day, we need to remember that that diameter is and that distance; those are two factors that are very important when it comes to suction.
Absolutely. And this is a place where there's been some interesting studies done that we should talk about for a second. So I found this one where they compared different suction catheters. Quote, 4 commercially available rigid suction catheters of varying internal diameter were tested against 3 different fluid viscosities. Wait for it. Tap water, Florida's natural, reserved mark, orange juice with pulp, which they say is medium viscosity, and egg beaters, reserved, which they say is high viscosity. And so the catheters
Mm,
they compared were the standard Yankauer, which is a 3 millimeter opening, versus the S3 trademark oropharyngeal evacuation tool, which is 5. Another one called the Big Stick, reserved, which is a 6 millimeter opening. And then finally, the Big Yank trademark suction system, which is
jeez,
9 millimeters.
God.
And particularly with those viscous liquids, the S3, the Big Stick, and the Big Yank. The Big Yank did 6 times better than the Yankauer.
Mm.
So it
You,
really does matter.
that's yeah. Yeah. I wonder what happened to the shop vac arm.
Right, exactly. Yeah, like there's room for improvement. Like
Yeah,
9 millimeters, oh please, with 12.
three
I think
centimeters.
right, like just like vacuum hose.
Yeah, exactly.
I think the moral of the story is that don't use those tiny flimsy catheters. They're very likely to be obstructed by solid debris. Imagine a pea is going to just block it off, and this is probably a situation where you want to be ready for thick, hot, or quote high viscosity fluid
That's right.
egg beaters.
That's right. Yeah. Usually when people are vomiting, it's not pure water. It's usually pulpy for lack of a better term.
With pulp, right?
Yes.
I want to say that sadly, critical care time receives no funding from Big Yank, Big Stick, or other big suction businesses, but we are believers in Post-Field's law here, and so for suction catheter size, specifically the diameter, really does matter.
That's right. What can I say? Girth raised to the power of 4. Um, so
um,
from there, I think probably we can move on to the last element here before we jump into some cases. So, Nick, once we think we've intubated a patient, think in giant quotes, what do we do to confirm placement?
Yeah, and I think this is a really important point to bring up with the anatomically difficult airway, because these are the situations where people tend to, get unrecognized esophageal intubations when it's really hard and you think you got it, maybe you didn't. And so it's really important to be sure. There's a couple of things that you can see. Condensation in the tube, that's nice. Um, Capnography, that's life saving. So, a lot of places use colorimetric capnography, which is not ideal. You should be using waveform if you have it. I think it gives you a lot more intubation, a lot more information. What is the end-tidal CO2? Does it follow the expected waveform, etc. Um, you can get fooled. Like there are case reports of like people who have like Alka-Seltzer in the stomach and they get an esophageal intubation and the Alka-Seltzer is producing enough CO2 that you get color change, like usually just
Oof.
once. The
Yep.
other thing is that if you get vomit on that colorimetric thing, the way the colorimetric thing is working is it's actually pH related. And so if you get acidic vomit up in the endotracheal tube and up into the colorimetric capnograph, it will cause it to change color. And so, I'd strongly push for waveform here.
Yeah, totally agree with you. Capnography, waveform capnography is definitely the gold standard. Colorimetric capnography, there's some issues there that make it not perfect, and definitely condensation, same idea. You can get condensation in the esophagus too. Other things I look at, so bilateral breath sounds, pretty helpful in general. If it's only unilateral, you've probably right main stemmed, but recognize in the heat of battle, you might think you're hearing bilateral breath sounds when in reality you're not. The other thing I look for is on the ventilator. So I'm going to look to see if you're getting good, believable waveforms that make sense. If your pressure alarms are going haywire, you may be down the right main. But again, it's not perfect. So really, I'm probably using all of these things together to make me feel a little bit better about, whether or not I'm in. And lastly, I'll say if I've got a bronchoscope, that's like the platinum standard, right? You throw the scope down, you take a look, and it's like, yep, there's the carina, I'm in.
Exactly. And I think, one other point is that sometimes people will get the laryngoscope in, they'll get the view, they'll pass the tube, and they'll immediately take their laryngoscope out. This is something I do a little bit differently, but I like to keep the scope in, especially the video scope, and then I can watch the tube the whole time. And this is two big advantages. Sometimes you are too deep and you have to pull back, and you want to make sure you don't pull out of the cord. So it's nice to see that. And two, sometimes like when people are bagging and doing all this stuff, like the tube is not adequately secured yet and it can get displaced. So I really like the security of continuing to have eyes on. It also means that let's say that we're in the wrong place. I'm one step closer to adjusting. Right? Like if I need to take this tube out and put another one in, I've already got my view. All I have to do is deflate the balloon, pull the endotracheal tube out, and then go in again. And so I would strongly encourage listeners to use, especially VL, throughout your confirmation process until you are truly confirmed and secure, get ready to secure, as opposed to just like, I got it, pull it out.
All right, guys. So we realized when we're recording this episode that there is just so much content here that we want to cover, a lot of good content in our humble opinions anyway, that we're going to need to break this bad boy up. So
we need a sequel to the sequel is what you're saying.
That's right. We need a sequel to the sequel. So stay tuned, guys. You've just heard part 1 of the anatomically difficult airway, and we've got part 2 on deck 2 weeks from now.
That's right. So we hear your feedback. Don't have episodes that are like 9 hours long. This isn't Lord of the Rings. This is critical care time. So just to summarize, on part 1 today, we talked about the anatomical difficult airway. We talked about how do you assess somebody? What tools can you use to try to predict or evaluate someone's airway, predict the difficult airway. We talked about what's in the toolbox as far as things to pre-oxygenate, decontaminate, access the airway, pass the tube, etc. We shared a lot of personal experiences and opinions. In part 2, what we're going to do is we're going to take that foundation we built today and we're going to cover some cases and we're going to do 10 lessons learned. So it's going to be a great episode. Don't miss it. Get excited.
And as always, if you want to learn more, you should definitely check out our show notes on the website, www.criticalcaretime.com. And while you're there, you can subscribe to our mailing list or leave us a comment.
So part of the show where we like to say thanks to all of our listeners. You guys encourage us. You get us excited to make more episodes, make more content. We love when you give us comments with ideas, suggestions. We appreciate your kind words. We really like your 5-star reviews. So please keep them coming. It really helps others find the show on their favorite podcast app. If you want to keep giving us feedback, feel free to tweet at us individually at Nick M. Mark or at Askins_Razor or collectively at Crit Care Time. You can also find us on Instagram and Threads.
And of course, we'd like to take this opportunity to thank our sponsor, C-Star Medical. We're fortunate and grateful that this episode and all episodes in Season 2 of Critical Care Time are sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Please check out their website, cstarmedical.com, to learn more.
And then before we go, we'd like to say thanks to everybody who makes this show possible, specifically the production team over at Podpaste, Kurt Belknap, who did our theme music. Couldn't do it without you guys. Really appreciate it.
And quick disclaimer for you guys. So the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. With all that said, thanks again for listening. We'll see you next week, or in 2 weeks rather. I'm Dr. Cyrus Askin.
And I'm Dr. Dick Mark. This is like the James Bond will return in part 2 of the anatomically difficult airway moment. So get excited. See you soon.